Welcome to a podcast brought to you by the American Academy of Orthopaedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, I'm Becca Catlin, member of the AAOMPT Research Committee and one of your co-hosts of this research-based podcast. Here we interview authors of recent peer-reviewed literature. These conversations allow us to go behind the scenes and understand the research questions, the thought process, and the methods that went into the development and outcomes of the studies and reviews. Our guest today is Dr. Justin Losciale, primary author of The Association Between Passing Return to Sport Criteria and Second Anterior Cruciate Ligament Injury Risk, a systematic review with meta-analysis. This was published in the Journal of Orthopaedic and Sports Physical Therapy in February of 2019. Our guest, Dr. Justin Losciale, is a board-certified sports clinical specialist with an interest in identifying strategies to improve the long-term outcomes of individuals following sport-related injuries. He earned his doctorate of physical therapy degree from Duke University in 2017 and completed a sports physical therapy residency program at Ohio State in 2019. He is currently a PhD student studying rehabilitation sciences and epidemiology at the University of British Columbia in Vancouver, Canada, under the supervision of Dr. Jackie Whitaker. He is studying the interactions between known risk factors for development of post-traumatic knee arthritis after knee joint injury. I'm excited to have Justin on the show today, so let's jump right in. Dr. Losciale, welcome to the podcast.
Thank you so much.
We're glad to have you.
Yeah, absolutely. Thank you so much for having me.
We'll launch right in, and I'll ask if you can give us the general purpose of your study.
Yeah, absolutely. So our big purpose and our big goal for this study is we really wanted to figure out and assess whether using some type of objective return to sport testing or criteria or test battery really resulted in a reduced risk of a second ACL injury. There were some other tertiary purposes, but really that was the big purpose of this paper.
Off the top of your head, you probably know the percent incidence of reoccurrence of ACL. Can you give us a little bit of those stats to show just the prevalence of injury post-injury?
Yeah, absolutely. So it really depends on what you read, and there's a lot of numbers that get reported. And whenever a patient were to ask me, after they've had their ACL reconstructed and we're chatting about their prognosis and what their rehab's going to look like, I tend to cite some work that was published in AJSM in 2016 by Wiggins, and they report about a 20 to 25% incidence of a second ACL injury. Doesn't matter which side. They also found that the younger you are, there tends to be a little bit higher incidence. But I've seen some numbers as low as 3%, and I've seen some numbers as high as about like 37%. So this is still an issue within our profession of how can we get these individuals, and they're not just athletes, but how do we get these individuals safely through their rehab and then transition them safely back into their activities. But it's also a fun story that you ask about statistics on second ACL injury, because we're currently also in the process of submitting a meta-analysis looking at the differences between males and females in second ACL injury incidents. So hopefully we'll be accepted to present that work at the now virtual CSM in 2021. And then hopefully we'll get that into print sometime in the next couple months.
Oh, excellent. And can you give us just a sneak peek? Was there a substantial difference between male and females?
In terms of the overall numbers, looking at it right now, and again, this is not peer reviewed just yet, but the overall numbers of second injury between males and females was about the same in terms of overall incidence. However, they have different patterns in terms of the proportions of injuries to which side of their leg. So either an ipsilateral injury or contralateral injury. And then I'll hopefully get that in print so then you guys can invite me back onto the show and we can talk about it.
Absolutely. I look forward to that. There is definitely a stereotype or perception about women and ACL injuries, so it'll be interesting to shed light on that with some more concrete data.
Yeah, absolutely. And that's why we went into it. We felt the same way that there is this very strong perception, and you see it in a lot of studies, that it's always females are at higher risk compared to males, and it's always the contralateral side. Not always, but a good amount of times, it's more contralateral injuries compared to ipsilateral injuries. And so we really said, okay, we're going to sit down and we really want to tease this out and make sure that that is the case, because that has so many implications for our secondary prevention programs, as well as potentially should impact how we think about and how we quantify some of the metrics that we potentially use in our return to sport testing as well.
Very good. That'll definitely help shore up some of the return to sport criteria, which is more the bulk of this study and what you're looking into. So, if we move more into the return to sport criteria, in your review of the lit, you made some comments about the lack of continuity with return to sport criteria. Can you shed light on that? A little bit of what's going on in terms of how people are putting together their return to sport criteria?
We started thinking about this study in 2017. Up to that point, there had only been, I believe, two recently published studies in British Journal of Sports Medicine looking at return to sport criteria that were very well publicized, that you started to see some of the main things that were included and what should be included, such as quad strength testing, hamstring strength testing, some hop testing, some subjective measures. But up to that point, as you dove into the literature, there were a lot of studies that just had these very brief taglines of athletes were allowed to return to activity after 6 months, or athletes were allowed to return to activity once they achieved symmetrical knee motion and strength. So, really, they weren't descriptive to any degree that gave us useful information, besides to say this is what we just made sure that they could bend and straighten their knee the same, and that they had a 5 out of 5 MMT essentially. We really didn't know what we were going to find in terms of what potential return to sport criteria were out there, and that really led us to think about this idea and this study a little bit more in terms of what our overall goal was, because we both wanted to really figure out what are the criteria used, what are the best criteria used, what should we be using. Unfortunately, we weren't able to answer all of those questions, but there was just a lot of uncertainty. And even going into the timeline, there was conflicting evidence about the timeline that you should follow. Some were following kind of the old school accelerated rehab. They get back to sport within 6 months after surgery. Others were eventually saying, no, we're going to wait till 9, 12, etc. months. Unfortunately, up to the point of this study, there was just so much variability, so much lack of description, and so much uncertainty in what criteria were even out there and were validly measured.
Well, I appreciate you doing the grunt work to get through all of those articles, because those are definitely questions that I've asked myself and tried to sift through the literature and come up with. Your project here was a systematic review with meta analysis, and you guys unearthed a ton of research. Can you tell me a little bit about your inclusion and exclusion criteria?
Of course. As we thought about it, because we said, okay, we're going to potentially get some studies that had some more subjective measurements, like based on the physician or the clinician's experience if they were ready to go back, or just based on time alone, or the patient's saying, I want to go back to sport. We knew we were going to pick up some of those studies. So we took a step back and we said, okay, we want to find the studies that have clearly defined some objective criteria that they use to make that return to sport decision. That was really the big piece of our inclusion criteria. But then we also said, okay, because we want to look at the association between that return to sport criteria and second ACL injuries, the studies also essentially they needed to track those people after return to sport testing for the presence or absence of a second ACL injury. And we also really wanted to look at how many people passed and failed. So just the sheer numbers to get a good idea there. So we also threw that in that they had to report their pass fail numbers. And that objective criteria piece actually became pretty important because we had two studies that we found. And initially, when we presented this at CSM, we did include one of them. And then through talking with people and going through peer review, we realized those weren't studies that we should include. That did include subjective criteria, such as the patient decided when they would go back, or it was based on a visual assessment and grading of their movement. So something that really wasn't an objective measure like quad strength on a biodex. And so we really needed to make sure we teased those out, especially after getting that really good feedback, and then only focus on these objective, measurable items within those return to sport criteria.
You ended up pulling over 2,000 articles and you whittled it down to just 4 studies that made your inclusion criteria. So there wasn't a lot of objective data out there.
No, which again was kind of shocking. We thought there would be more, but there just wasn't. And there were a lot of those studies that we were screening out at the full text level. We had about 100, 130 or so to screen at the full text level that just included these little taglines of muscle strength was measured to determine readiness to return to sport. But then they didn't actually report how many people passed their muscle function criteria, because it is very unlikely that all 100% of your cohort passed your muscle function piece. We know that doesn't happen. There are plenty of studies that have looked at just the ability to meet limb symmetry index guidelines. We know that doesn't happen in this population, and sometimes never does, even 2+ years after ACL reconstruction. And so it was a bit of a bummer, as you're going through and you're parsing through all these studies. It's kind of a bummer that you're like, oh, we're going to have so much data. And then you go, oh, we only have 4 studies. But the 4 studies that we did get were wonderful studies that did add a lot of value and really helped answer this question in a really good way.
That surprises me too. My perception is that ACL is one of the most popular areas to study, and every journal I pick up has at least one article on ACL. Might be an exaggeration, but it seems like this is definitely a highly researched topic. So to come up with just 4 really solid objective measures in just these 4 studies is interesting, but hopefully helps set the bar for future researchers.
It really does. And I think we've already seen since the publication of this systematic review, we've already started to see a couple other study groups across the world who have started to publish very, very similar studies looking at their return to sport criteria and second injuries, and also playing around with some of the comparison metrics and like the passing and cutoff scores that I know we'll talk about in a little bit as well.
Yeah, I would love for you to give us a little bit of information about the 4 studies, specifically their return to sport criteria. So this might be looking at the table 4, a little bit about that information, and just describing what some of their criteria was and how they measured it. Also, were they pretty similar in how they chose their return to sport criteria? Did they vary vastly in what they chose to include in their criteria?
There were definite similarities in what I consider kind of the big 2 that are almost always included and should be included within your return to sport criteria. And that is some measure of thigh strength, so quadriceps and hamstrings, whether it was isokinetically done or isometrically done. All 4 studies had that. Now, they varied in the methods that they tested it at. And so for the isokinetic testing, some did 60 degrees per second, 180, 300. Some only did at 60. So there's some variability there. All 4 studies used the single hop for distance. Then 3 of the studies used the triple hop, 3 used the triple crossover hop, And then after that, it's extremely variable. We had one study, a singular, out of the 4 reported an agility metric using the t-test as part of their return to sport criteria. The same study required their athletes to do a sport-specific rehab, and they defined that a little bit within their study. But then 2 other studies, and these were both from the Delaware Oslo cohort, they used a subjective report of knee function. But those were the only 2 that did any type of patient-reported outcome measure as part of their actual return to sport criteria. So after the big 2, it is very variable. And even within those big 2, the methods that they use to determine what those numbers are were slightly different as well. So there's still some ambiguity and some uncertainty as to, okay, I'm going to measure thigh strength. Well, how should I exactly do it? What's the best measure? There's still some uncertainty there as well.
And it doesn't look like anybody did hip strength, and we didn't get any analysis of landing mechanics via more of a specific biomechanic analysis. So that it wasn't that complex, which is good because most facilities wouldn't have the capacity to turn around and do this in their clinics as a nice and concise return to sport panel.
Agreed. Yeah, there's still some unknowns, and even within this, one of the big things that's missing, apart from biomechanic analysis, and there are some good, more clinic based, like the landing error scoring system, the LESS test, that could have some value based on your patient population. But the one thing that was really missing from this, and we know now how important it is, it's a measure of psychological readiness and or fear of movement, fear of returning to sport. That was not included in any of these. And so I'm very curious to see in the future when that gets added into these return to sport criteria, how does it potentially change the numbers? Because we're seeing some really great literature regarding measures like the Tampa Scale of Kinesiophobia or the ACL RSI out in Australia, and their ability to pretty well predict a second injury. More to come, hopefully, in that realm.
Thank you for mentioning that. I think that is a key area as well. And that is really just bubbled up to the surface in more recent years as pain science and more emphasis has been made on the psychology of people. And we don't think of athletes very often, though they can be in the chronic pain scenario. It's just helped shed light on understanding what their fears and their underlying beliefs are.
It's true. And if you work with these patients in the clinic and you watch them try to land from a box, if you're doing just like a drop vertical jump, even whether it's for assessment or training, you watch them land, and some of them look like deer in the headlights. They're terrified. And that in and of itself is probably a much bigger factor than how far they're hopping, because if they're fearful of trying to land, if they go out onto the field, guess what? They're going to be fearful of trying to land from a jump. And potentially that's when bad things happen. It's such a critical area. I wish we were able to find something in this paper that did have some data. Unfortunately, it just wasn't there just yet. But I think down the pipeline, we're really going to see some interesting findings, and that really may change the ball game in this realm.
I agree. If you can tell us a little bit about the subjects that were in these studies, was there some consistency in terms of their level of athleticism? I assume these were all athletes, male, female, high school, college, pro. What was the homogeneity of the subjects?
In terms of male females, they were about equal, probably a little more males than females. We tend to see that in just absolute numbers. We tend to see just a few more males than females. And that just goes to males are playing additional sports like football, where they're tearing their ACL, versus females are not playing things like football. In terms of activity level, this is where there was some variation. One study by Kyritsis et al., that's a very unique study in that they only analyzed male professional Qatari athletes. very, very specific. And the clinic that they operate out of is a top of the line sports medicine clinic out in Qatar. And so they were only analyzing their male athletes there. There were other studies that looked at people that are in level 1 or level 2 sports. So people that are doing some strenuous knee heavy work. And then we had some that were just recreational to competitive athletes, and it was just kind of a hodgepodge in between. The nice piece about the 4 studies is they were fairly representative of what you would expect in terms of age, where the age ranges were anywhere from about 20 to 27, 28 years old. So a pretty tight age range there, which was really good. But in terms of sports that they played, it all over the place in terms of sports. We've got a lot from the European side. So a lot of people playing handball, football, basketball, a lot of soccer players within the Qatari group. And so kind of a hodgepodge in all types of sports and graft types as well. We saw mostly bone, patellar tendon, bone, and hamstring, some allografts, but mostly bone, patellar tendon, bone, and hamstring grafts within these. But again, it was hodgepodge across the studies.
And you said they were mostly all patella or hamstring grafts, and they were autografts?
Mostly all autografts. There were some allografts included as well. 69 allografts within the Nawazre, I hope I pronounced that correctly, study. And I think that was the big one in terms of allografts. The rest were all autografts.
Okay. So you aggregated the data from these 4 studies and came up with your test result definitions. Just so we can understand the results, maybe give us a little bit of how you aggregated the information and how you reported it.
Oh, of course. First, we looked at the numbers in terms of, and we extracted pass fail. So, how many people passed their defined return to sport criteria? How many people failed? How many just total people suffered a second ACL injury? And then we further broke that down. How many people passed and suffered a second ACL injury? How many people failed and suffered a second ACL injury? And then how many people didn't within those 2 groups as well. So we had to break that down there for our main primary analysis to determine the risk of a second ACL injury, as well as to just get the baseline numbers of how many people are passing, how many people are failing, and what's the true incidence of a second ACL injury based on if you passed or failed. Then we went a little step further and we said, okay, we're going to kind of think about this as like a screening test, because in my mind, it's a giant screening test. You want to screen that these athletes are ready to return to sport, and you have to go from there. So we had to think about it almost like a diagnostic test, and we had to try to figure out, okay, well then how do we define a positive test? How do we define a negative test? And so we reported that in our first table, in table 1 on page 45. We thought of a positive test result as if someone failed return to sport criteria. So we caught them. We caught the person that in theory isn't ready. While a negative test is someone who passed their return to sport criteria, where, okay, great. They, at this time, based on these metrics, were saying that they're sufficiently ready to go back to sport. And so those are the big definitions that we used and how we kind of teased out the data to set up our analyses within this study.
And then from there, go ahead and tell us what your results found.
In those 4 studies, we pooled them all together. The big things that we found within looking at just the incidences, go into table 3, when we looked at just how many people passed and failed. So just looking if you can meet your return to sport criteria or not, almost 60% could not do it. That is a very bad number. And we'll talk about what we think causes that, but there definitely needs to be some work there. Even now, as we're starting to measure things, if people can't meet these criteria, even though some of them are very baseline, that's an issue because it just doesn't seem like they're ready yet.
60% did not meet the criteria, and yet they did go back to sport.
They did go back to sport. Yep. Then when we looked at how many people suffered an ACL graft injury, so an ipsilateral injury, Within the people who failed their return to sport criteria, about 12% had a graft injury. And within the people who passed, about 6% had a graft injury. So, okay, we're starting to see a trend there. Then contralateral injuries, and this was kind of interesting. The people who failed return to sport criteria had a 4% incidence of a contralateral injury, while the people who passed basically had about an 8% incidence. The people who passed are potentially seeing more contralateral injuries. But then when we looked at the overall numbers, they were about the same. So for people who passed their return to sport criteria, about 14 or so percent will sustain a second ACL injury. The people who failed, about 15 or 16% will suffer a second ACL injury. So fairly similar there as well. That led us into our next analysis, which was to determine the association in essentially looking at the risk of sustaining another ACL injury based on just if you passed or failed. And unfortunately, none of our analyses there reached any statistical significance, likely because they were just a little bit different in their findings, a little bit different in their source populations. But what we did see was that trend that we saw with the incidences started to show within these risks, where people who passed return to sport criteria tend to seem to have a little less risk of a graft injury, while the people who passed also seem to have a little bit more risk of a contralateral injury. Again, none of those reached statistical significance. So when we had to conclude what our findings were, we couldn't conclude that there is or isn't an association with second ACL injury risk based on if you passed or failed your return to sport criteria.
Were these results surprising to you or not what you
I
expected?
thought we were going to find, and again, admittedly, I was a young researcher. This is my first publication, and I was so excited. I thought we were going to find these really robust findings and change practice and all these different things. But once I looked at the numbers, the second and third time, I said, okay, no, this is what the data is telling us. Yeah, I'm a little surprised that it wasn't a robust decrease in risk of a graft injury, but this is what the numbers are saying right now. But as I look into it more, I think if we add a couple more studies, we may see some different findings as well.
So you're not ready to throw the baby out with the bathwater. The return to sport criteria that were chosen to be put in these studies probably still have some merit.
Oh, absolutely. And they do. And they have merit on multiple levels in terms of what they tell you. Yes, they tell you the obvious, how strong they are, how far they can hop relative to the other side. Maybe you do a patient reported outcome measure so you get their perception of their function. So, yes, that's the obvious that it tells you. But there's so much more that these metrics in isolation and in combination can tell you. Especially now, we're starting to see some really good data coming out looking at things like quad strength and the definition of like functional performance. So essentially, like if you passed or failed your return to sport criteria, and long-term outcomes such as NEOA in this population within the first, I believe it's 5 years. So we're starting to see some direct associations there. You can also look at just quad strength in and of itself at the time to return to sport. The ACL relay study coming out of Cincinnati Children's and Ohio State, they've basically found that in a younger population, when they have quadricep weakness compared to the other side at the time they return to sport, that's associated with altered biomechanics and sometimes in more high risk biomechanics for things like a second ACL injury or the development of NEOA. We see deficits still in gait mechanics in those people who have thigh weakness. Just because right now we can't really confidently conclude that there's an association between return to sport criteria and a second injury, there is so much that you can read between the lines and so much more that using these measures, again, in isolation or in combination with each other, can tell you about this patient's long-term prognosis and may then give you areas where you say, okay, I really think we need to keep doing this. I really think we really need to keep strengthening your quad, or we really need to work on your fear of movement and try to normalize that for you so that you're okay with doing some of these just basic tasks.
I would agree. And honestly, I can subjectively, so not founded in research, but the strength issue is so important across the board for a lot of the diagnoses I treat and across the age range. So I might have a 60-year-old chronic lumbar patient and find, due to inhibition and atrophy, a lot of weakness. And I find that the stronger we get them, the more symmetrical we get them, the better the outcomes. So I think that can't be underestimated. And unfortunately, in the general clinic setting, we don't have the visits
Yeah.
to bring them to the level that I'd like to take them, but at least I educate them on that.
No, and that's what we can do as physical therapists. It's try to generate or educate them on that behavior change of this lifelong process of physical activity and exercise, and within some cases very targeted exercises towards specific deficits that we know are going to be helpful for them. And yeah, we may not be able to do it within the scope of the physical therapy plan of care due to whatever reason, most of the time insurance and visit limits and all that other stuff. But if we can enact that change for forever, then I still think we've won. We got to win there. And I think that patient is going to have a much better quality of life and a much better outlook on whatever it is going on with them, regardless of the diagnosis. I always tell when I was working with students, there's going to be patients that you're going to run into where you're very uncertain about what's going on, what you should really prioritize. And I always think about it. I was like, well, no one really ever gets worse when they get stronger. So I guess I'll strengthen them.
When we look at the limb symmetry index in the past, a 90% to 95% between non injured versus injured has been considered a good cutoff. More recently, it's been bumped up to 100%. Can you shed light on that limb symmetry index?
The main measurement that we see in almost all of these studies is the measure of limb symmetry index. So taking the involved side, comparing it to the uninvolved side, times it by 100, you get a percentage. 90% traditionally been the cutoff. Within these studies, 90% was the cutoff for hop testing, for quad strength, hamstring strength, etc. There's been many studies that have advocated for much higher, for 100%. But unfortunately, there's so many issues with limb symmetry as the comparison metric in and of itself, because there's a natural detraining of the uninvolved limb that happens fairly quickly after the ACL injury due to a variety of reasons. We're essentially comparing the involved, the surgically repaired limb, to not a true estimate of what it should be. I believe it was just before this paper was published, another paper in JOSPT out of the Delaware Oslo group basically found that when you look at LSI at the time of return to sport, it greatly overestimates their function, which makes sense. However, and you talk to a lot of scientists about this, and as I've learned more and as I'm going through my research training right now, trying to find a different metric is really hard. Getting baseline data and then following those people and tracking it and creating normative values, it's really hard. It's really time consuming. It's very expensive. As of right now, it is the best metric that we have, which is unfortunate. But I know because of those limitations, there are a lot of researchers that are trying to play around with different metrics, whether you're taking their strength value that they get from their biodex and normalizing it to their body mass, or trying to compare it to some control people that you've brought in for the same study to give it more of a relative to what are the healthy limbs like, relatively similar to this person. So that has some potential value, and I'm really excited to see if those can improve that metric a little bit. And the same thing with hop testing. Comparing it to the other side, there's evidence that shows it's really not the best metric for hop testing. So taking a look at it relative to things like their body height or their leg length. That's been done a couple times and reported. Those different measurements could really change the ball game for us. And so I'm excited to see some literature that comes through the pipeline. Hopefully, maybe there'll be some at CSM this upcoming year and then in print within the next year or two that might be able to help that out a little bit.
I would be excited to see that as well because I've often felt the same thing that comparing to the uninjured side doesn't necessarily give us a great bar to shoot for.
No, unfortunately not. But I think when you're in the early stages of rehab, it's a nice metric. Towards the later stages with true athletes who are trying to go back to some high level knee strenuous sports, that's when we're going to have to really dig in and really try to identify those better metrics. So again, fingers crossed, we'll see.
And then just as a take home message for in the clinic, this speaks to continue to train each limb independently, especially for muscle isolation training and working on muscle hypertrophy. The statements you made of asymmetries persisting long after the surgery, and our brain's ability to offload the injured side unwittingly. Have you seen any benefits of continuing to train or ways that you train to get them back on the field?
So I've toyed around with this, and in residency, I was so lucky that I had so many people to bounce ideas off of and see what they've done. And, of course, the priority is the surgically repaired side, but the issue is, you can't detrain the other side to meet symmetry. That's just a really bad way to go about it, in my opinion. We need to train both sides as if everything is normal. You have to train both sides. Some strategies I've done initially, and unfortunately I don't have any data besides my anecdote if they're helpful or not, is I just adjust the volume that we're doing when we're doing isolated work. So if I'm doing knee extension and hamstring curl, so more isolation type movements and open chain, the involved side's going to get 4, 5, 6 sets. The uninvolved side's going to get 2, 3. They're going to still get trained, but they're just not going to get as much in those early stages. And then I try to normalize everything as much as I can in terms of the volume later down the road. But I think it still has doing isolated training for both sides, I think has value throughout rehab. I think it has value when you're trying to bridge the gap from rehab to getting them back to their actual performance level, which we know that's also a big issue. And then for maintenance after they've returned to performance. So I think it has value across the continuum. And that's one of the reasons we speculated that the people who returned to sport and who passed return to sport testing and saw a higher contralateral injury incidence, we said, maybe either the contralateral limb was detrained, which allowed them to pass, which put the contralateral limb now at risk, or maybe the metrics just aren't stringent enough. So not maybe 90% should be 100%. And there's still that unconscious offloading of the involved limb for whatever reason to the uninvolved limb, which puts it at higher risk. And so there's so many different angles to look at it. And we haven't even gotten into talking about things like neuroplasticity, which could have some big implications within this realm for both second injury and the rehab component. I think the best thing that we can do is we have to train both sides. Yes, priority needs to be given to the involved side, but we still have to make sure that we're not purposefully detraining the other side.
Agreed. probably have a tendency in my own clinic practice is they get farther in their rehab, gravitate towards functional training. Could be unilateral, but also bilateral. Just reminder to myself to maintain the muscle isolation training for just simple hypertrophy.
Oh, absolutely. And it's tough, as you get toward those later stages of rehab, you really want to do all these functional things that are more sports specific or more targeted towards their activities, which is fantastic and it's awesome, but there's still that blend that needs to happen between maintaining their foundational strength, working on different components of fitness and muscle function, like working on power and their elastic ability within plyometric training. As someone who has a sports background, who had access to communicate with athletic trainers and strength and conditioning coaches, that's where that team environment, I think, has the absolute most value, in that you can work together to make sure that each one of us within the healthcare team is making sure that we're addressing each of those components within our specific times with those people. And I know not every patient has that. Not every patient has a strength and conditioning coach, a personal trainer, and a physical therapist. It's mostly just the physical therapist. And then that's where you just have to get creative in how you're prescribing your exercises when they're not coming into PT. What are you really having them do in their off days? I know right now with COVID-19 going on, sometimes getting to the gym just isn't physically possible because they're closed, or people are worried about their health and safety and the health and safety of others. So this is a really challenging time. And I was listening to a talk by Kate Webster from Australia, a very prominent ACL researcher, right when COVID-19 hit. And she was saying it's going to be very interesting to see what this subset of patients that just had ACL reconstructions or are now having ACL reconstructions in the time of coronavirus, what do they look like in 6, 12 months, 2 years from now? Is there a huge difference because they didn't have access? And are they at an even higher risk of a second ACL injury? Or is it the complete opposite? And that would just blow our minds, I think.
Well, that'll be interesting. There's going to be a lot of interesting research that can come out of coronavirus and the change it's created in society. In your discussion, you talked about several co-founding variables that might have impacted the results, and we've talked about a couple. We mentioned the psychological impairments, and we were just talking about some return to play. What about time from surgery to return to play, or even the biological healing side of things? What do you think about those impacts on risk for injury?
I think it's the one thing that we can't see as clinicians. We can't measure biological healing. We can't see it happening in real time, which is a bummer. It is important. It really is. Previously in ACL literature, it was just time based, and they would say, okay, you're going to be good in 6 months because that's when everything's healed. More literature comes along, and we realize, oh, that's not correct. It really does. The graft takes about anywhere from a year to 2 years to mature, and it just depends on who you are and your biology. And we do, as clinicians, we do need to respect that. And I think we need to do a better job of really informing the patient about that, as one of the reasons that we're saying, hey, this is why we're going to go slow and make sure that you're not really getting back into the sports type stuff until about 9, 12 months after the surgery, because we want your graft to be, from a healing standpoint, rock solid. But also, then you just get more time to work on those really important deficits. So once you get people to buy in, then it's great because now you have all this time to really work on things. It is such an important factor. If an athlete is ready based on the return to sport criteria at 6 months, in my opinion, looking at the data, make them wait. Educate them on why you're advocating for that. Make sure you've got everybody on board, the physician, their parents if it's a younger athlete, their coaches as well, if they're okay with you chatting about it with their coaches. but you need to approach it from a team effort and team-based perspective.
The education is so big, and that's a lot of what we do as PTs. I've dealt with younger athletes who are just dying to get back onto the court or onto the field, and they're like, I feel great. I want to go. Why can't I go? So I think your point is well taken of the entire team giving the same message and making sure that the adult or the coach in the scenario is giving them the same information and getting them to understand that the tissue is still healing and it's not 100% even though they feel good. Well, this has been a great conversation. Is there anything else that you could add or want to add?
No, I think we covered all the main points. Yes, this study didn't find what we expected to find, which is okay because that's research and that's science. But the main findings need to make sure that they're not misinterpreted, that return to sport criteria isn't valuable and doesn't work. It still is valuable. It very likely still may work. We just need a couple more studies. And if we add that data in, we're likely going to find an actual association and effect between passing return to sport criteria and second ACL injury risk. So that's the big thing that I would like people to understand is, yes, we didn't find an association, but that doesn't mean it's still not important. It's still not valuable, and you shouldn't strive to at least get your patients after ACL injury to some level of baseline standard, if not higher and better.
Thank you so much for your time and effort on this study, and I will definitely look for you at CSM.
Absolutely. Thank you so much for inviting me. It's been absolutely fantastic. Hopefully, I'll be back on sometime in the near future.
Yeah, thank you.
This has been a production of the American Academy of Orthopaedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.